So, with a great deal of joy, I would like to raise a hand, raise a glass, raise my eyes, raise my spirit, and be very happy to invite Ms. Laura Cox to talk to us about all the aspects of lactating and feeding human milk to little human beings that then grow up and hopefully do better things than some of the adults that are already running around doing things. So take it away, my friend.
Oh, thank you so much. It is such an honor and pleasure to be here. Like always, I just love seeing all of your beautiful faces. Um, I don't think I need to do an introduction. I think everybody here kind of knows me. I did a bit of an introduction on the Facebook thing, so I'm not going to soak up a bunch of time doing that. I do kind of want to do a little bit of a different thing this time around, just to kind of get our brains moving in lactation. In the world of lactation, we have a lot of swirly things happening in our lives right now, including all these birthdays. Whoop whoop! I could not feel more at home with all these Virgos. I'm sending you all of the birthday organizing, prioritizing vibes to you all. I would like to ask, as I would like to put out here right now, just with y'all, just off the cuff. What are some things that you hear in the community about breastfeeding or chest feeding or human milk feeding that you know are myths, or you know are not true, but you're not sure why they're not true? Is there anything out there that you're hearing out when you're out there in the community where you're like, that isn't right, or I know that's not right, but I don't know why that's not right, or I've heard that's not right and I don't understand that's not right? Anybody have anything like that out there in the universe today?
I have something I can share, but I can't quite write it. I can't write it in the chat.
That's okay. You don't have to write in the chat. You can just
Okay.
spitball it out. Yeah.
Something I was thinking of, and I think I have things I could answer, but I was also kind of taken aback. Someone said to in like some group I was in that the only benefit of breastfeeding compared to formula is that it's like better for kids who have diarrhea or something. Like that's the only benefit, or research proven benefit, the researched benefit. And so I was like, and this came from, they got this from, who was that? The skeptical OB or whatever she calls her.
Oh, yeah.
You know that, you know who I'm talking about, right? Yeah.
Yeah.
So I was like, when she just said that, I was like, okay.
Yeah.
But that
Yeah.
basically it has to do with like, yeah, I don't know, dysentery or something.
I love it. Yeah, diarrhea, which is, I think, if I'm not mistaken, is one of the top 3 leading causes of death and
Yes.
globally. So, I mean, diarrhea is it's not just something to poo-poo, pardon the pun. But yeah, let's play the game. I like this game. I'm going to share screen if that's okay with y'all. And I'm going to, oh, I need to do it this way too. So pardon me here. So we have, no, hopefully y'all can see this. Can y'all see what I'm doing here with my?
Yes.
Perfect. Okay. So we had back in 2011 the amazing Dr. Regina Benjamin, and she was the Surgeon General for 2011 in that in the Obama administration, and she's done lots of amazing things in her life or in her practice, but one thing that is pretty amazing was that she asked the question of what happens when you don't provide human milk. So to kind of go off the the topic that you brought up, Mika, was that, you know, human milk is only beneficial for people that have diarrhea or babies that have diarrhea. And so she wanted to prove it, and she wanted to prioritize funding, right, to prove it and to do that research. And so she did, because she's amazing. And so with that, they asked, well, what are the excess health risks associated with not breastfeeding? If breastfeeding is relatively the same as formula, then what happens when we don't provide human milk? And with that then came like this, you know, deluge of information and research towards what we know about human milk. And so let's go with babies first because they're cute, and I want to talk about babies first. So what they did was they came up with this excess risk, and so the excess risk is really like an odds ratio of information of what is the ratio of me getting this acute ear infection. And so it's a measurement of association between an exposure and an outcome. So if the exposure is human milk, then the outcome would be one of these conditions, right? If this baby had human milk, what is the risk of them getting an acute ear infection or eczema or diarrhea? And so we can see here with this chart, and these have been updated since I've posted this. This is back in 2010, and I can share the link to this data if that's something that you're interested in. But we know that for a fact now that human milk or intake of human milk can prevent or reduce an excess risk of getting an acute ear infection, or especially among our preterm infants, the necrotizing enterocolitis. Now, that is a specific I'm not going to say a disease, a specific condition that happens to preterm infants, in that bacteria will proliferate within the gut. And because their immune system is so compromised, they can't fight off that bacteria, which causes really just portions of their gut to die, and causing them at higher risk of getting sepsis, among other things. And that is, I think, like mostly preventable if we used human milk instead of formula. So we know that there's this overwhelming amount of research that shows that human milk is beneficial for infants, both our preterm infants and our term infants. But then you hear conversations of like, well, it's only beneficial for the first 6 months, or it's not beneficial in the second year or in the first year, or extended breastfeeding isn't beneficial. And we kind of go into those kinds of conversations as well. And we do have research that shows that human milk is beneficial not only for the breastfed baby, for like what I mentioned before, the excess risks, or some people have found it, some research has shown that it has higher performance in intelligence tests. And then they have less risks for, obesity and heart disease. But what we're also finding is that there is nutritional benefits for that toddler to receive human milk as they're starting to bring in solid foods, because the intake of solid foods is not going to be adequate for the nutritional needs. And that's where human milk can also come in, as well as we still have this increase of immune factors that happen in infancy, and then as well as baby starts to go into being a toddler. And then, so we know what's going to happen for baby. What are the benefits for the lactating person? Well, if we play in the world of the extended breastfeeding, if we were to provide human milk or lactate for 12 months, what we can see is reduced risks of postpartum anemia, reduced risks of type 2 diabetes, hypertension, hyperlipidemia, cardiovascular disease, as well as breast and ovarian cancers by 26 to 37%, as well as a reduced risk of obesity in postpartum and beyond. What we also do see is if lactation goals, if duration of lactation is cut short, we have a significant increase in risk of postpartum depression. So if that person is not reaching their lactating goals, then we know that they have a higher rate of becoming depressed. And so that's meaningful, especially as we start talking about, we're starting to highlight more about postpartum depression, and other mental health disparities that especially among our postpartum population. And then finally, we can look at benefits to society, right? So what are the benefits to human milk for society? We, of course, have no manufacturing pollution or product transport or packing in landfills. You know, if 90% of families could breastfeed or chest feed for exclusively for 6 months, we could save, you know, in the United States about $13 billion per year and prevent, you know, around 900 deaths, which nearly would all be infants due to the factors that I mentioned above. And then, of course, your employees are less likely to miss work because their babies are healthier, and then healthcare costs are less. And that's also very attractive. Finally, I've always been that person where, you know, if somebody in my family has like a rash or something going on, like let's put breast milk on it. Let's put breast milk on it. And finally, I said, like, you know what, I got to do research and find out if this is this actually true. Like, can we prove this and research that you know,
Monday you would prefer Friday.
Oh, let me see if I can.
Yeah, but he just want to see you one day.
Well,
you just want to.
Well, at least as far as.
I'm sorry. Is it possible to mute this person? I don't think they realize that they're on. Oh, there they go. Yay! Woo. Okay. Sorry. So I do research to find if, in fact, it is possible to, you know, relieve certain conditions with human milk. And I found a few studies that's called milk therapy, which I thought was really cool. And they have research to show that milk therapy can help with diaper rash or eczema, umbilical cord separations. Of course, we all knew that nipple pain and damage can be relieved through human milk, as well as eye problems like viral pink eye and the such. So there you have like this roundabout bit of information about how human milk is beneficial, not only for the infant, but for the lactating person, for our community, for our climate, and now for all these random things like nipple pain and cord separation and eczema. So yay, there's that. And so hopefully that is that kind of addresses that human milk is a little bit more beneficial than just for babies that have diarrhea, although diarrhea is problematic. Anybody have any questions or concerns about benefits for human milk or Dr. Regina Benjamin or milk therapy or any of those other things?
I love how you were able to just pull all that up.
It is. I know it's actually pretty. So you should see me at parties. It's not. it's not surprising.
It feels almost like maybe like you knew I was like we seeded this. We really didn't, and that was amazing. So thank you.
Yeah. You're welcome. I like playing this game. It's a lot of fun because I feel like you all out there are professionals and you've been supporting the lactating community for quite some time. So like I could go through this whole presentation and stuff, and I'm more than happy to do that. But sometimes it's kind of good to start off with like, let's talk about something that's like really weighing in your mind when it comes to lactation. I feel like that kind of allows us some space to kind of engage with each other for a second. Anybody else have anything that they're seeing out there in the community, things that they may hear that they may know that is true or not true, or they don't understand why it's true or not true?
I'm just hearing from the group of lactation educators that I support. Every month, I'm hearing from them about specifically Black and brown babies, but babies being born, and then the nurse in postpartum saying, your baby's not going to get enough and I need to give them formula. Like across the board. And it's so infuriating for folks that really want to feed and are like early in their journey and that separation happens. But that seems to be like really standardized in a lot of places.
Yeah. Well, I do have a slide for that, but it's not very. I mean, I do have kind of a slide for it, and then I'm going to lean into the other part of it. So, and you all may have heard this lecture before. but I'm going to go over it again because we could talk about really why early supplementation is very problematic when it comes to the course of lactation. And then I'll speak a little bit more about the, about specifically, why do we have Black Breastfeeding Week, and why would we supplement in the hospital, or why do people push for supplementation in the hospital? And I can speak a little bit to that as well. So let's start with my favorite here. Okay. Let's describe the supply and demand cycle of human milk production. And since I think that a lot of you already have a pretty good grip on the phases of lactation, I'm going to do like a broad strokes and the such. And if you need more clarification or more deep in depth, please just jump on and stop me at any point. So there are 5 stages of lactation, but for this sake, I'm really just going to focus on 3. But it's always good to have broad, understanding of the phases. And of course, like I said, when you're at parties, you could talk about the stages of lactation, because that's exactly what I do. Or on public transportation, for that matter, you can spit a little lactation knowledge. It works out really well. Anyway, so stage 1 is pretty much self-explanatory, right? Mammogenesis is mammary glandular growth and development. I'm really not going to go much more into that. But stage 2, this is the first stage that I would really love for you to have a good understanding of. And there are really 2 things that I want you to remember when it comes to lactogenesis 1, which right here, it starts 10 to 14 weeks gestation. I actually call this the Whitney Houston of lactation, because you're every person, I'm every woman, you're making cardiac muscle, you're making eyeballs, you're making fingernails, and you're making milk, right? You're every person. The second thing I want you to remember when it comes to lactogenesis 1 is that there are 2 hormones in play, progesterone and prolactin. And whenever progesterone's around, it will always inhibit prolactin, right? It's like the man. It will always keep prolactin down. So I have any kind of circulating progesterone, it will always inhibit prolactin's ability to help facilitate making milk. Now, prolactin is the hormone responsible for making milk. And if it's suppressed, then obviously to impact your milk supply or impact your ability to make milk. And I'll go more in depth about prolactin in just a minute. So hold on tight. So with let's see. So with progesterone, it's like the man, it's always going to keep prolactin down. And so we don't really need a lot of milk, remembering, right, in lactogenesis 1, because we are at 10 to 14 weeks gestation. We don't have a baby on the outside, so I don't need to really make a lot of milk. But when baby does come out, I do have a little tiny baby with a little tiny tummy. And it's this relationship that creates colostrum, progesterone and prolactin. And the relationship of lactogenesis 1, we're going to be making colostrum. So the combination, I need to move your pictures. There we go. Oh my goodness, that's so much better. Oh, let's see if I can even move it a little. Sorry for the technical difficulties, but you're blocking part of my screen and it makes it really challenging to see. Okay. Thank you. Sorry about that. So during lactogenesis 1, the combination of progesterone and prolactin together make up this super powerful concentrated milk that is colostrum. So again, 2 important takeaways when it comes to lactogenesis 1 is that we have 10 to 14 weeks gestation, so it's the Whitney Houston phase of lactation. And second, because of progesterone circulating due to the placenta, it will inhibit prolactin. So like the man, progesterone will always keep prolactin levels down. It is this relationship that creates colostrum. So moving on to lactogenesis, there are 2 things I want you to understand about lactogenesis 2. Anybody have any questions about lactogenesis 1, placenta, progesterone, prolactin, the man? No. Okay. So lactogenesis 2, there are two things I want you to understand. The first is that it starts 2 to 5 days after delivery, right? Not at the delivery of the placenta and not at the delivery of the infant. Now, I'm sure you're asking like 2 to 5 days, that's a significant amount of time, right? Like why we have such a wide range of things, a wide range of time between something happening. I'm sorry, hold on one second. Are you ready for me to move?
Oh, we're just eating out here.
Are you sure?
Yeah.
Okay. Sorry, we have dinner going too. So babies need to be fed and showered and the like. Okay. So 2 to 5 days range. Why is there such a wide range between 2 to 5 days? 2 to 5 days is due to the fact that number one, diversity is the spice of life, right? We're all very different. So is this the first time this person's had a baby? Is this the first time they're going to be lactating? Did they have a postpartum hemorrhage? Do they have other factors that play a role in like their endocrine system that can impact their ability to release prolactin or progesterone? There's a bunch of different factors that contribute to why we have such a range. And right now we're even beginning to discover gestational diabetes plays a significant role in this as well. So we're learning more and more all the time. So because of that, we're going to have this span of 2 to 5 days. But I think to go back to the original reason why I started talking about this, 2 to 5 days can also make people feel really uncomfortable, right? Because colostrum, you're not making a ton of colostrum. Remember, you have progesterone and prolactin, so your milk supply is going to be pretty low. But if your milk supply is low and you're making this super concentrated, super powerful, super awesome milk, right? People are looking to feed the baby. We got to feed the baby. I got to have a lot of milk, right? And instead of continuing bring baby to breast like we expect in those first 5 days, right? This cluster feeding, and even the baby initiates this cluster feeding. They are constantly on the breast every hour, every 2 hours, fussy at the breast. This is what gives people permission to say, well, baby looks hungry, baby is fussy, baby is constantly on the breast. Therefore, we should start supplementing. And this is where the biggest issue, at least early phase of lactation, this is where the biggest issue lies, because babies are not dumb. They know that they have to go to the breast and get that colostrum for their immune system, but they also know that they have to go to the breast to increase milk supply. And I'll talk about that in just a second. So when we transition into lactogenesis 2, the placenta leaves, and over the course of 2 to 5 days, with nipple stimulation and milk removal, the body will get the signal that we've made a baby on the other side, and now our milk supply needs to increase. Progesterone will completely plummet out of this picture, and prolactin will skyrocket, and it'll be the highest it will ever be, ever, in any of this relationship. Prolactin will be at the highest. Now, we associate this phase as your milk coming in. Now, I find that to be a very interesting phase or phrase, because when I say we're going to wait for your milk to come in, or your milk will be coming in, the power no longer belongs to me. Right? Your milk will come in a couple of days, or we're waiting for your milk to come in. I have no power in that sentence. I have no power in that statement, because I'm waiting for something to happen. But that's really not what's happening. I was Whitney Houston, a couple weeks ago, and now I'm waiting for something. Whitney Houston does not wait, right? And neither do we. Through nipple stimulation and milk removal, our milk will increase in volume, right? That's what I want, because I already have milk. My milk isn't coming in through anything. My milk was here, and now it's going to increase in volume. Thumbs up, milk increase in volume. Okay. So why do we have this like copious amounts of milk? Well, at this point, our body doesn't really care how many babies we've had. Did we have one baby? Did we have 5 babies? Are we nursing this baby and our neighbor's baby? Am I nursing this baby and my cousin's baby? Boobs don't care. At this point, they're just gonna like, you know what? We'll just nurse the entire neighborhood, and then we'll fix it all later. right? We'll sort it out later. And that's pretty much the mindset that they are in until we hit the galactopoiesis. Now, galactopoiesis starts at 9 days after delivery. And this is what we commonly refer to as the supply and demand phase, right? And this is how we know of lactation, right? The more you take out, the more you make, and the more you make, the higher volume you have, and so on and so forth. So this is the most common phase that we associate, but the last two phases had nothing to do with supply and demand. They had everything to do with our hormones at play, including progesterone and prolactin. Okay, so does anybody have any, again, I'm doing broad strokes. Does anybody have any questions or concerns about the phases of lactation, transitioning between lactogenesis 1, lactogenesis 2, or galactopoiesis, and how that works, especially in an inpatient setting, and why that 2 to 5 days can cause a bit of a kerbuffle?
Can I ask a very specific question?
Absolutely.
So I had a client whose OB wanted her to go home with birth control. And she didn't want to do IUD. So the OB recommended a progesterone only birth control. Yeah. But that sounds very contradictory to what you're saying.
Yeah.
So can you tell? I don't know. That was actually one that I was like, oh. It sounds so contradictory. But they say that's the one that's the best for breastfeeding.
That's right. And so that's right. So progesterone only pills are exactly as they sound. They are progesterone only, meaning you're taking in progesterone, right? But the trick with progesterone only pills, the caveat that is mostly used is that we have to wait for the milk supply to be established. And with milk supply being established, at that point, we can add in other factors like taking in progesterone only pills, or the mini pill is what it's also been known to what I've also known it as. But then there's other factors that contribute with milk supply as well. As when your menstrual cycle comes back, estrogen can also inhibit prolactin, right? So you're going to see people that have, when they start their cycles, a few days before their cycle starts, when their estrogen levels are really high, their supply will tank, and then it will come back. Milk will taste a little bit different due to estrogen levels. So there's a bunch of different factors that contribute to what inhibits prolactin. But because supply is already established, this part's really cool. I even think I have it here in my, do I even have it here? Oh, I hope I do. Let's see. Oh, yes. Oh, okay. So what's really cool, I'm jumping slides, so I hope I'm able to maintain my train of thought. What's really cool is that, so let's see if I can go back. I'm going to go back here and talk about prolactin receptor site theory, but I'm going to kind of break it up a little bit. So it is our posterior and anterior pituitary gland. It's actually your anterior pituitary gland by your hypothalamus that releases prolactin, right? And as it releases prolactin and it hits up with these prolactin, and it establishes itself in its prolactin receptor sites. What ends up happening is that these prolactin receptor sites start to create prolactin inside the mammary gland, inside the breast, inside your cuboidal epithelial cells that make milk. And because of that, now you have a separate entity, a separate place that's making prolactin, if that makes sense. That it kind of like creates its own little manufacturing section of prolactin. And so when you take progesterone, and although you have progesterone circulating, it's not going to inhibit prolactin to the point where it's going to tank your supply. Now, will it for some? Absolutely. And that's the other thing I say about ingesting your placenta. When people ingest their placenta, they take in progesterone. And so that can impact your milk supply. But for the majority of people, it doesn't impact their supply enough to stop them from meeting their breastfeeding or chest feeding goals. At least that's what according to research says. And you have the risk benefit ratio, right? This person getting birth control is a little bit more important than the risk of impacting a milk supply at 6 weeks, if that makes sense. And so they get to make that decision for themselves. Ugh, I hope that I answered that question. Does that make sense to everybody? I hope. And I'll go back and explain like cuboidal epithelial cells and prolactin receptor site theory. I'll go back to that so that everybody understands like how that works. But that's why progesterone only pills aren't inherently to the mass population going to impact milk supply depending on when they take it. So I would recommend at least, at that 6 week appointment, 6 to 8 week postpartum appointment when you start talking about taking birth control. Then, and hopefully that answered your question.
Are you there, Mika?
Maybe she had to step away. Was it Mika? It's hard to see people because I have my slide deck open. I'm sure she'll jump on if it didn't. But I'm going to go back really quickly to, okay. Let's like take a step back for a second and look at inside and see how we're actually making milk, right? So this is a human breast or chest, just in case you weren't aware. This top portion here is a non-lactating breast, and this bottom portion here is a lactating breast. This portion here, this is what's happening during lactogenesis 1. It's the development of what we call alveoli. They are also known as encines or lactocytes. And they are really what's responsible for making of the milk. Here at the bottom, you can see this middle picture here is the middle, or I'm sorry, a full alveoli, and here is an empty one. And these little guys here, these are cuboidal epithelial cells, and they are, again, like what I said, responsible for making milk. And you can see they are lining these this alveoli on the inside. On the inside of the alveoli are these cuboidal epithelial cells. On the outside are the myoepithelial cells, and those are responsible for milk ejection reflex. So when oxytocin floods the system, it hits these myoepithelial cells, these little webby doohickey things. And when oxytocin hits those and floods the system, hits those myoepithelial cells, and they squeeze as a reaction to being saturated with oxytocin. And as they squeeze, they eject milk out the ductal system and out of the nipple. This is what we know as the letdown or the milk ejection reflex. Hopefully you all have seen this video, and hopefully you can hear it. Can you hear it? So you're like, Laura, what am I looking at here? Laura, everybody, you are looking at cuboid or the myoepithelial cells being saturated with oxytocin, and they're squeezing milk outside into the ductal system and out of the nipple. And you're like, why am I listening to this like slow jazz music? Well, you have to remember, right? Oxytocin is the love hormone, right? So we have to set the stage, get a little groove on, because oxytocin is hitting that system. And this is milk ejection reflex or letdown. Now, just a big caveat, oxytocin hits us all very differently. Some people feel, they may feel really tired. Some people feel really nauseous. Some people feel really hungry. Some people feel really sad or anxious. So it's always good to check in with people about how they're feeling with letdowns. Because remember, they're going to be doing this, 8 to 12 times in a 24-hour period at least. And over time, if somebody continues to feel anxious, that can really impact their quality of life, right? I'm gonna let this video finish because it's really cool. Okay, again, really broad strokes, doing it really quickly. Anybody have any questions on milk ejection reflex or the letdown? Everybody doing okay? All right. So you've heard me say that when those myoepithelial cells are saturated with oxytocin, they squeeze and they hit the ductal system. What does that mean, ductal system, right? So milk travels through these highways, these super highways that we call milk ducts. You may hear people say, I have a clogged duct or a plugged duct. This is where part of the pathway from the alveoli are blocked by fat, or it could be based off of edema, swelling, due to too much fluid or infection that can clog a duct, preventing milk from passing through. When milk becomes stagnant, meaning when milk doesn't move, you're at a higher risk of infection. Milk has about 600 various types of bacteria in it. And remember, we also have sugar in there, lactose being the primary sugar. So if milk stays in one place for a significant amount of time, that increases our risk of that bacteria to proliferate, causing infection, such as mastitis, or we can even go as far as to say abscesses in the breast, which is just a no bueno situation all the way around, right? I have this picture here because I want you to understand. So you have your alveoli, right? Just like how I brought up to you in that picture before, and on the inside where there's cuboidal epithelial cells, on the outside with the myoepithelial cells. When a bunch of alveoli are together, it's called a lobule. So a gaggle of geese, a lobule of alveoli. And so you have a bunch of them together in their lobule, and then they go down the ductal system. Now you're like, I'm sure you're wondering, Laura, why did you cross out milk sinus? Well, what we know, first off, nobody's breast or chest looks like this. Nobody's ever this symmetrical. It doesn't look this even. And then the second is what we know now is very different than what we know. So what we knew then, this was back in 2021, this picture, and we know that milk sinus isn't necessarily a thing anymore based off of our anatomy. What does it look like? This here is a more accurate representation of what our lobules look like, where fat is distributed, and how the ductal system works. The Cooper's ligament, that's what helps keep our breasts up in theory. And you have different types of fat that play a role inside the breast tissue. So then you've heard me talk about how I got milk out as people, right? And you've heard me reference cluster feeding and baby going to breast every hour and being fussy at the breast, right? So then clearly the next question is, why do babies suck? Now, if you have kids, that's a really loaded question. Today, we're just going to stay in lactation. And there are really two reasons why babies suck, at least in the very first 0 to 5 days. One is that baby needs to poop. Remember, you're not allowed to poop in the pool in utero, and you're not allowed to poop in the pool on the earth side. So you've got to come out, and babies need to poop to reduce our risk of jaundice, among other things. The second, though, is to increase prolactin receptor sites. Now, you've heard me speak about prolactin receptor sites. So let's go back and do a breakdown of our hormones. Oh, this is all... Oh, I'm sorry. I'll fix that in a little bit. So a breakdown of our hormones. So we start to have increased circulation of progesterone in 16 to 22 weeks within the phase of lactogenesis 1. Remember the Whitney Houston phase. And as we start to have increased progesterone due to the placenta, because that's what's feeding, that's what provides us our progesterone is the placenta. As the progesterone decreases, our prolactin will increase due to nipple stimulation and milk removal, right? And that'll be the highest it'll ever be. But if I don't have any way for those cuboidal epithelial cells to receive the prolactin, then I could have an entire system flooded with prolactin and I will not be able to make enough milk. Those cells have to get the have to get the stimulation from prolactin in order to make milk. And the only way that you can get the stimulation is through prolactin receptor sites. And now, so that leads us to prolactin receptor site theory. So remember, we have these cuboidal epithelial cells here on the inside of this alveoli. When prolactin floods the system, if I don't have enough prolactin receptor sites, they cannot stimulate to make milk. So baby sucks, right? Providing nipple stimulation and milk removal. Prolactin is released from the anterior pituitary, floods the blood system, right? And it reaches the outside of this alveoli and the inside of these where the cuboidal epithelial cells are. And they bind to where progesterone originally was, causing, when progesterone leaves, prolactin takes their space, kind of like a car in a car parking lot. When the car leaves, prolactin pulls in, and then therefore can cause stimulation to therefore increase milk supply. Now, again, this is known as prolactin receptor site theory. Everything is a theory until we do more research and find out more information. So my next question when I was doing research on this is like, well, we already have to have some prolactin receptor sites, right? Because we're making colostrum. If we're already making colostrum, then some prolactin receptor sites have to be there. I did some research. So according to Freeman et al., prolactin reduces its numbers of receptors in the cell, which results in low milk supply, or in this case, lactogenesis 1's colostrum. So when we have progesterone, which inhibits prolactin or acts like the man and keeps prolactin levels down, but prolactin also regulates itself by reducing the number of receptors on the alveoli, which means that we have this super concentrated milk, but not a lot of it, because some of the alveoli are not getting the signal to make milk. Once progesterone is gone due to the removal of the placenta and we have nipple stimulation, prolactin levels increase by way of the pituitary gland. And then while the system is being flooded with prolactin, prolactin also increases its sites to increase the message to the cuboidal epithelial cells to make milk. And that is what contributes to prolactin receptor site theory. So more nipple stimulation, we gain more receptor sites. The more sites in the alveoli, the more alveoli and lobule make milk. But we do need to have nipple stimulation. And if we, but we don't need nipple stimulation, meaning, and this is where in the hospital it starts to go awry. We don't need nipple stimulation in that, oh, baby can nurse for 10 minutes on each side and then be all done. It doesn't really work this way. We need to have that constant message that baby needs, that constant message to make milk, to release prolactin, because that's how prolactin receptor sites are going to get, that's how prolactin is going to make more prolactin receptor sites. So we need to have more frequent nipple stimulation and milk removal. We need to stop putting times on people, 10 minutes on the left, 10 minutes on the right, nurse every 2 hours, because when things go differently, which they will, because babies are different and people are different, then that gives us cause to assume this person doesn't have a milk supply or this baby needs more. And that's when interventions start to really impact the dyad, and that, oh, well, let's just supplement a little bit. And every time we supplement, person doesn't get nipple stimulation or milk removal, or they do, but they do through a pump. And pumps remove milk via suction. Babies do not remove via suction. They remove milk via compression. So our bodies aren't really meant to respond in that way. So when we don't tamper with the system, it's actually a very perfect system when it's allowed to work on its own, which I'm sure as doulas, you could also appreciate that is similar to birth, right? The more we tinker and stick our fingers in things that don't need our fingers, the more issues arise, right? And then that brings me back to this slide that I kind of buffed up at the beginning, talking about how we are able to create our own prolactin receptor sites. Actually, they've recently found that prolactin is actually in milk because of the increase of making prolactin inside of the cuboidal epithelial cell. And they found that prolactin contributes to neuroendocrine and immune systems in research involving rats, which I thought was really interesting. So really cool stuff as far as I'm concerned. So that was a crazy long explanation as to supplementation and why people feel driven to push supplementation. Hopefully, and then kind of leading into prolactin receptor site. Does anybody have any questions or concerns? Need me to go back and explain something a little bit deeper? Anything at all?
Laura, something that I've seen a lot is the push to get new parents a pump, and like when you're in the hospital or like when you're first like discharged, you're like qualified to get a pump, so you need to call in a certain amount of time, and the lactation consultants I feel really push that. And how beneficial or disruptive is that pump usage? What is the like timing around that in your experience and opinion?
So like I mentioned before, pumps remove via suction. Babies remove via compression. So anytime that I'm going to recommend a pump, it's always going to be after. I can probably do this with latch too. Every time I'm going to recommend a pump in terms of usage, it's going to be after the milk supply has been established. So preferably after when we start to get into galactopoiesis, that's where it's helpful. Pumping is helpful for whenever you're away from your infant, then you can create a storage. Like in theory, that's what this is for. Oh, you're going to go back to work, you're going to go back to school, you're going to go out on a date, you're going to go do other things that don't involve your infant or require you to be away from your infant. That's where pumps are useful. And again, all in theory. Now, when you have babies that have latch issues, then we start to go, or structural issues with their mouth or any of the other factors. Then now we have to lean definitely into pumps, right? Because baby can't do it for whatever reason. Or NICU families that also have profound separation between their infant, profound separation or inability to latch, for that matter. That's when we would start doing pumps. But in general, I always would recommend, if we have to do any kind of expression outside of the baby's ability to remove milk, it's going to be hand expression. Hand expression is a skill that is it's clutch when it comes to lactation, right? You don't have electricity, you forgot your pump parts, your insurance company decided to change regulation and now you don't get access to a pump. There's so many other reasons and factors that can contribute to people like, well, I can't pump, so therefore I can't provide human milk, right? Hand expression is great. As a matter of fact, I have this amazing video. I won't show it to you, but it's done by Vanessa Simmons. And she has a website and a YouTube video. I don't know if you've ever heard of it. I'll put it in the chat. It's called normalizebreastfeeding.org. I can't do the chat when I'm sharing screen. I can. I just need to figure out how. Here it is. Sorry. So here's her website. And then she also has a YouTube video. That's what this is right here. And she literally, she expresses 3 ounces in 4 minutes via hand expression. It's insane. It's insane how fast she's able to get milk out, but she's really trying to push forth this narrative that hand expression is far more efficient. It's cheaper, and you already have all the equipment. And then finally, there's a little bit of research that talks about fat content in hand expressed milk versus pump milk, because again, pump milk is removed via suction, not compression. So the kind of milk that's coming out by pumps is different than milk that's going into babies either directly or by hand. And that's a big difference, right? When you have a baby of low weight, or a NICU baby, right? I need all that fat. I need all that stuff. And getting milk out by pumps isn't going to really help with that. Or I take that back. Hand expression may be more beneficial for that dyad. So long story short, if I'm going to recommend a pump or any kind of anything, it's going to be hand expression. If I'm going to say that they should pump, I'm going to do it when milk is established, because pumping isn't going to be as efficient with milk removal, because it's just not the way we're meant to respond. And I would recommend hand expression because it's better.
Awesome. Thank you, Laura.
Super long answer. I apologize for that. I get a little excited. Any other questions or concerns? Everybody's good?
Mm-hmm.
Anybody have, I can go back to the top of what I was going to discuss, but does anybody else have anything like they want to shout out in terms of conversation, skills that they maybe want to brush up on, how to get baby to latch? What do we talk about with hand expression? Anything like of the sort? I can go back to where I started. Okay, well, I can definitely go back and kind of jumped all over my slides. This is a lot of fun, actually. It's like rogue lactation lecture here. All right, I'll go back to where I started. Would it be okay if maybe we took like a 5-minute bio break?
That would be great.
Samsara, would you be okay with that?
That's fine. Let's do that. 5 minutes.
Okay.
All righty. Is everybody back? You ready, Laura? Take it away.
Sorry, I had to grab a little bit of my husband's dinner. It's Taco Tuesday.
Ooh,
So good.
delightful.
It is. Okay. All right. So I'm going to try to go back to my slides, and we're talking about prolactin receptor sites. They're how they establish how prolactin establishes prolactin receptor sites, and how that's regulated through progesterone through the phases of lactation. And then, as we know how this works in our system in our body, as the people that have breast or chest, right? Then what is the stomach capacity, or what are the roles of the infant, or how does that work as well? And so it would be beneficial to always look at stomach capacity as well, because this is something that I see in the hospital a lot. Now, I am a postpartum nurse. I work over in a community hospital in Oakland. And what I see frequently is overfeeding of that 0 to 2 or 0 to 3 new 3-day old infant. What does that look like? Supplementation that would take, 25, 35, 40 mLs in a 1-day old baby. So it would be beneficial to look at, like, what is the stomach capacity of a day 1 old infant. Now, again, these are big general, these are like general numbers, right? Not every baby in the planet that's born has a 5 to 7 milliliter stomach capacity, but in general, we do see that babies can hold between 5 to 7 mLs due to the size of their stomach. If we have an infant take in 10, 20, 30 mLs of anything, human milk, formula, anything, that will absolutely impact lactation, in that a full baby is not going to go to the breast frequently. And I just described a little while ago why it's so important that we need to have continuous nipple stimulation and milk removal from that infant in order to increase and establish our milk supply. And so by supplementation, which is its own game, I actually did some research a little while ago and found it was through the CDC, where at least half of our population in the state of California babies were getting supplemented with either formula or donor breast milk. It was like 53% of our day 1, day 2 postpartum dyads are being supplemented with something other than the milk coming from their breast or chest. So supplementation in an inpatient setting is very, very common. And we're seeing it more and more frequently, and we're using it as a way to establish milk supply or address issues so that we can increase breastfeeding longevity. But that isn't necessarily the way things are going, right? It's not increasing exclusivity, meaning it's not increasing babies only getting their person's human milk. That's for sure, that's not what's happening. And it's not increasing longevity. People are still not able to provide human milk at 3 months and at 6 months due to the systemic issues that surround our ability to care for our babies or to feed our babies. And that of course, disproportionately impacts our Black and African American communities, our Hispanic communities, because those are the rates that are starting to, again, continue to decline. But you are seeing those rates of initiation, and they're all the same. Everybody is trying to breastfeed, or they are initiating breastfeeding in that first day. Unfortunately, because of all these different caveats, that's becoming more and more problematic. And that's something I see in my hospital quite often, where I will be caring for a baby. They'll go to the NICU for whatever reason, and that baby had received 40 mLs every 3 hours, which is just not sustainable for a person that's trying to establish a milk supply. Does anybody have any questions about, sorry, I kind of went on a bit of a tangent there, but does anybody have any questions or concerns about stomach capacity? No questions. Okay, great. So again, just like big broad strokes, with lactogenesis 1 and lactogenesis 2, any increase in nipple stimulation can increase prolactin receptor sites. The more sites equal longer breastfeeding. The amount a baby sucks from 0 to 5 days absolutely impacts and affects milk supply at 3 months. There is no such thing as baby pacifying. So that's something I hear a lot as well, is my mom said, don't let baby pacify me. Or my sister said, don't let my baby treat me like a pacifier. Or they nurses say, don't let baby just sit there and pacify on me. Between 0 to 5 days, that baby is providing nipple stimulation and milk removal, even though they're not actively sucking or actively removing milk, right? I call it nursing, where they're sleeping, but they're on the breast and their mouth is kind of moving. You know what I'm talking about? So we're not actively drinking, but we're still providing nipple stimulation. All that oxytocin from that baby smell and that skin to skin, all of that stuff is happening in those moments, even though baby may not be actively eating. That is so important. And that is where that dyad needs to stay together. That's where if I see grandparents holding babies or friends holding babies or anything, I am absolutely that horrible nurse that will take that baby and say that baby needs to go with that person and needs to be on the breast, and they just need to be this huddle of oxytocin over there, and we can do all the things to support them without holding baby. So that's my little hill I'm going to die on, I think. So over the next few days, sucking becomes more efficient and milk supply increases. Does anybody have any questions about that?
Not a question, say, but just a general irritable comment about what is up with this culture, man. The baby's happy,
right?
Some people are just enraged at a little child getting suck needs met, touch needs met.
Yeah.
You know, and for the parent to be enjoying that. I mean, there's something about that that just makes some people wild. And in certain aspects of our culture just gets really like, I don't know if they're jealous because they didn't get that need met. That's probably it. But it's so destructive. You know, why shouldn't the parent's body bring peace, pacification? Why shouldn't the parent's body bring peace to the baby? Why is that a problem?
I'm 1000%. You're speaking my language. That's it. That's my love language as far as I'm concerned. I 100% agree. I feel that I would love to actually hear a doula's perspective on this, but as a nurse, I feel that having limited amount of people in my postpartum room to establish milk supply and allow that person to start the recovery process with less family and friends and things going on in that room has contributed to better lactation outcomes. I don't know if we'll see that in the data, but I will say that baby is on breast more frequently and person is willing to breastfeed a lot more than if we had more family members there that need to hold the baby or need to give feedback on what's happening or need to have involvement. Are you all seeing that where you're coming from in terms of birth or in terms of postpartum? What are you all seeing?
Well, it's an interesting thing. I mean, you know, I think the less that family is present, the more one feels comfortable to be opened enough and skin to skin enough and naked enough to be enjoying that juicy breastfeeding relationship with your kid. But families have forgotten how to be families, in my humble opinion, because if you look at indigenous folks, the family's all around. but they're being helpful. They're not trying to sit and play with the baby. They're helping the dyad, they're helping the mom, they're cleaning things, cooking things, saying prayers, doing stuff. And this culture has this, and plus also you're sitting in a hospital. What's there to do? Watch Jerry Springer? I mean, he's dead. So, there's that. But we it's part of the dissolution of the village that we don't know what to do other than come and glom on the newborn. Like there's a lot to be done. There's a lot that could be being done other than just, sitting with the baby. But
yeah, that's an excellent point. I didn't really even think of it that way. We've lost how to be a family. I think that's a very interesting, profound point. Yeah. Anybody else like to share their perspective on what they've seen in their practice, or what they feel, especially now that COVID restrictions may be coming back or may not, or depending on where your people are giving birth? Anybody want to share their experiences?
I would say like a big difference I've seen pre and post pandemic is that with one of the benefits of the restrictions, I think, is having less extra family in the hospital postpartum has meant more connection in the between the dyad and in that relationship. I always have a lot of conversations about this, like explicitly name what kind of help is supportive, the concerns, around help being hold the baby. Like it should not be hold the baby so that you can go do dishes, right? Or whatever. But I have seen that, but like also to Samsara's point, like we do need that. We do need people around. We just need them doing helpful things. I remember having one family after me like, Mika, you're so right. Our parents just left and we shouldn't have had them here. Like we needed the helpers and they were not the helpers. So I've definitely had those people tell me that too.
Yeah, I see that especially with my hypertensive patients. More families around, the higher my blood pressures are, the more interventions we have to do with you postpartum because of it. And I don't know. It's just an interesting thought that I've seen just working inpatient. Yeah. Anybody else? Sorry, I hope the noise isn't too much. There's dishes going on and stuff because we're getting ready for settling down into bedtime. So please let me know if the ambient noise is too much. Anybody else want to share their experiences of what they're seeing out there? Interventions of people around in lactation.
I just wanted to say, a lot of times, like with breastfeeding moms or chest feeding moms, there's different aspects and different things that may affect the milk load or the flow of it coming in. And so what suggestions do you give to clients that have a life that is not necessarily conducive to being able to actively keep up with their flow of nursing and making sure that their milk is coming in, just due to like stress and workload and life in general? Like, what kind of suggestions do you have for just like transitioning into something that is conducive with a busy lifestyle?
Man, that is such a great question. That is such a great question. I mean, I think what I've always found in terms of supporting people, supporting lactating people is, first initially establishing or saying out loud what their goals are. What are your goals? What are you looking for with lactation? Do you want to breastfeed or chest feed for 2 months? I've had patients where like, I just want to breastfeed for 2 weeks. What can I do for 2 weeks? Right? I love it. 2 weeks. That's great. that's your goal. That's where you're at. Let's get you breastfeeding for 2 weeks, and then let's have you stop lactation safely. So establishing a goal and saying that out loud and whatever that is. And then from there, you're able to, you're kind of able to navigate. So for example, if I have a person, it's like, I don't want to feed baby from the breast, but I would be interested in providing human milk. Great. Let's make sure that you have access to a pump. I'm going to teach you hand expression and all of those kinds of factors. If we're going to do mixed feeding, how can we do mixed feeding safely with keeping your milk supply established, right? So that first part of it would be, would it be possible to exclusively breastfeed for the first 2 weeks? Is that doable? Like, what does that look like for your schedule? And then navigating from there by introducing either formula or express milk or donor breast milk. And from there, you can you can take the next steps. I think in general, if I'm going to do like a broad answer to that question, it would be, is it possible for us to establish milk supply? Like, where are they in terms of bandwidth? Is that even possible? Can you exclusively breastfeed for 2 weeks? And then if that's not possible, then from there we can figure out how can we maintain this person's milk supply, and then what are other options that we can do to support this person. I think that the biggest takeaway in general is that the power needs to be in the person of the lactating person. This person gets to decide what they want to do. And I feel like with lactation, that's not something that is very often done. Like, as you can see in our language, we're waiting for your milk supply to be established. Like, we're waiting for your milk to come in. We're doing all these things where you don't have the power. Baby-friendly hospitals, there's a lot of, you can't use pacifiers, and we're not going to supplement, and we're not going to do formula, and you can't do this and you can't do that. And they're really pushing lactation, which, I guess that's a totally different conversation, but the power is within this person. So what do they want? Having had all the information, what is the decision that they're going to make that's best for them and their family? And then we can work through it that way. But in general, I would recommend establishing milk supply by exclusive breastfeeding in those first 2 weeks, and then tackling issues from there, if possible. Yeah. Hopefully that answered your question, or maybe sparked some more questions or comments.
Yes, that's good.
Awesome. Thank you. Anybody else have any other questions or concerns?
I sometimes get questions about supplements, like,
yeah,
like, should I buy these supplements? Especially, are there like some kind of cow? I can't remember the name.
Yeah, cow colostrum. Have you seen that? I saw.
Oh, I know about. Oh, I love me some cow colostrum, but no, like the name of supplement. No, I was thinking more of like herbs.
Yeah.
Yep.
Yeah, honestly, I'm not a huge fan of I don't recommend any supplementation, especially if I don't know medical history. Like fenugreek, I think that you can't take fenugreek if you have a history of diabetes, or if you have some kind of cardiovascular or lipidemia, hyperlipidemia issue, because that can be exasperated through fenugreek. Well, just the amount that you would have to take for it to impact your milk supply. There's a bunch of different supplements that you can take. I'm definitely not going to dissuade somebody if that's their cultural practice by any means. But, so far, everything that I've shared with you is based purely on how we operate as human beings, having and chests and pituitaries and hypothalamuses and all of those things. And if those are in working order, then we don't really need to do much else other than exist. But I'm not anti-supplements, because again, I want to acknowledge that there's a wide variety of cultural practices surrounding lactation, and some of them do include using Greeks herbs and tinctures and all of the like, and in general speaking, I would definitely not persuade someone not to do that, especially if that was part of their cultural practice. But if you're coming to me just like as a human, Laura, dude, should I take this because it'll increase my milk supply? I'm going to probably tell you no, it won't increase your milk supply.
Especially if we're not talking about all the other factors, like what are you eating? How are you
Yeah.
eating? Are you hydrated?
Yeah.
The supplement's not going to magically make the milk burst forth from your breast with no work from you yourself. So, we kind of get a little like supplementation is extra, it's a supplement, right? So, we can totally respect cultural practices, with the understanding that part of being a healthy human is that you have access to good food and water and you're healthy. And you might use the supplement as a supplementation, but it's not the driving force of what's making the milk.
And I think just to go back even to the previous question about how do we help support somebody that has, extenuating circumstances like crazy schedules or high levels of stress or all of these other combating factors that can contribute to decreased milk supply or inability to provide human milk in some fashion. And I think that really is going to another big factor that can help mitigate some of that is support. Where are these people getting their support? Do they have do they have partner support? Do they have family support? Do they have community support? There's research has been showing for quite some time that if the lactating person doesn't have the support of their partner or of their family, their lactation goals are cut significantly shorter than what they wanted them to be. Research is showing that doulas are literally saving lives by being there as a support person, both intrapartum and postpartum and antepartum, right? So we're seeing that the levels of support are clutch in terms of us as being birthing people, being able to carry babies to term, birth those babies safely and healthfully, and then provide human milk for them and stop whenever we are ready to stop. So I feel like that's another huge big factor that I would like to put out there into the universe. And then of course, thank you all as doulas for being the badasses that you are and for supporting birthing people. Do we have any other questions or concerns before we move forward?
I wanted to I had this one situation that happened recently that I don't know, I've just been thinking about in general with specifically things that do happen in the birth that make sense why the milk would be delayed a bit, or something has happened and there's so much pressure and for somewhat good reason of breastfeeding. And then there's this line that's drawn of like, it's really hard for people to know when to supplement when they're seeing all of these cues that baby's hungry and they're feeding all of the time and they're trying to hand express and they're trying to pump and nothing's coming out, and they're getting this feedback from so many sources of like, just keep doing it. And then they get to their pediatric appointment and they're like, your baby's losing all of this weight. And so I think that situation just becomes really hard, even from our doula perspective of like more skin to skin, like all of these things. But I don't know that line of like, when is it not quite enough in that specific situation, and like, figuring out how to supplement with the lowest risk of interruption. But I see those situations so frequently turning into not being able to breastfeed exclusively when it starts out that way. So I don't know, just thoughts on that when people do have the time and the capacity to do all of the things and are doing all of the things and still not making enough milk to support the baby. I don't know, conversations around that. Which you kind of mentioned that with like, what are your goals and like, how can we make sure that your needs are met? But yeah. And then in thinking too about like IVF for people who have had issues getting pregnant and like the hormonal imbalances and how do we know if that's playing a role in it? So yeah, question around that, if you have anything.
Yeah, I love that question because that's really a lot of what we're seeing in the community. I've supported quite a few people as they start to make that pathway of like, when do I supplement? What does that look like? And then I feel like there's not a lot of acknowledgement of and I'm sure that you can also equate this in with what you're seeing in birth, but this mourning of loss, right? This mourning of a loss of a intervention less birth, or a mourning of losing the idea of a term baby or a healthy baby or milk supply, or all of those things that you have to process and mourn. And I feel like also in addition to that, it's also very stressful. It can kind of like, what does it say? Like, a watched pot never boils. It almost like a similar aspect, right? Like, just keep doing. You're going to make milk. And you're like, oh, I'm going to make milk. You're now also consumed with pump every 2 hours and do all these things. And so that your cortisol is just so high, based purely on the fact like something magical is supposed to happen. I'm doing all the things, but the magical thing isn't happening. And you're right, going back to things that happen in the birth that can contribute to that. People that have PCOS or any kind of issues with hormones before pregnancy, that can absolutely impact milk supply. Excuse me. Anybody that's had breast reduction or augmentation, that can impact milk supply. People that have lost a significant amount of blood, that can impact milk supply. Those that have taken on a bunch of fluid, or people that have gestational diabetes, that also impacts milk supply. And we're just now learning all of these things. And so then the question is like, if I know that my patient is going to have, or my patient or my person or my client does have one of these factors, how do we navigate that? Like, how do we move forward? And I feel that, again, going back to, when I'm talking with this person, am I acknowledging the power that they have, right? And if not, then I want to give them that power. For example, if my client has breast augmentation, history of breast augmentation. I just had a patient about like that a couple of weeks ago. Breast reduction specifically makes it very challenging because you remove the nipple, and as you remove the nipple to take out as a part of the process of the surgery, you sever the nerves, and when you sever the nerves, then lactation is kind of based off of nipple stimulation and milk removal. And if you don't have nipple stimulation, then that makes it really challenging, because the signal going from your breast to your brain to release those hormones are compromised, and therefore will impact your milk supply. And then you also have removal of glandular tissue as they remove the fat, as they remove the adipose tissue. And so with that, then you have this increased risks of low milk supply or no milk supply. And when I had my patient, she came to us postpartum, and she said, I had breast augmentation. I still would like to breastfeed. And it's like, okay, great. So we're going to put baby on breast, and we're going to do it frequently. But we also know that you have this potential of low milk supply. So what are things that you're interested in doing? We can do an SNS. Let's see, I think I have a picture of that somewhere here. Here. We can do an SNS system, which is this picture here. We can do hand expression and pumping. We can bring baby to breast. We can do all these different things to create this potential. And then she got to decide, right? She didn't want to do the SNS initially, and then she tried it later on. And we did all of these things, but those were all her call. And so when she didn't have a milk supply, which is what she expected, then she was okay with it, right? Like that was something she was able to move forward with. For other people, sometimes like, you know, it's not the same. Breast augmentation is not the same as a postpartum hemorrhage. It's not like this person went out and said, well, I think I'm going to lose 2 liters of blood, and then that'll impact my milk supply, right? And so it's those factors where you can say there's the potential that you're going to have a low milk supply, but let's, you know, hope for the best and prepare for the worst. And I feel that having those very real conversations early on allow people to make the decisions that they need to, meaning like, I've tried all the things, I'm exhausted, I don't want to do this anymore, and have it be like, you know what, that's okay. That's what you need, and that's what I support. Allowing them to mourn whatever idea that they had for lactation, but then also helping them pivot. What does that mean? Should we do donor breast milk? Do you want to keep trying and then we supplement because you do have some milk? All of those things. That's kind of a really very long-winded answer, and I apologize. But I kind of just wanted to do like a broad idea of how I would address that issue, because there are so many factors that can impact milk supply.
I think that's wonderful what you're saying, Laura. I mean, what I'm hearing from what you were sharing is a big reduction in potential shame for the lactating parent, and why, you know, people are feeding your little offspring is such a primal thing. And the folks who want to do it, it's coming from this beautiful, pure place that is out of the cultural norm. It is out of the cultural norm to be wanting even to do this. And so to not be able to do it, people feel badly. So like, how do we move them out of feeling shamed around it? You know, and so much power is lost birthing in the hospital, I just gotta say. So you know, what comes up for me and what I do as a doula is I do my best to prepare people ahead of time so that they know, like, you know, Pitocin can delay the milk coming in. There are things that I gotta, this, if this happened, this might happen. And then it's not a big surprise. And then it's not something for them to fall into shame about. You know, so I just think as much trying to, you know, go back to empowering people. You know, and there are times when you need interventions that will jack up plans a little bit, but at least it's very different when something is happening that you expected and you know why, rather than you thinking you did something wrong or there's something wrong with your body, which I think is the wrong thing.
Thank you, guys.
I think what I see a lot is that, you know, they don't want to give up unless they've tried everything. I have to have tried everything. I've had to exhaust all the things, right? And that for me, in my Virgo space, when I hear of try everything, that means I'm just absolutely spinning my wheels. I'm just going 20,000 miles per hour and trying to just try everything I can without it even making sense. And I've kind of lost myself in that. So when I do support people, and you know, I get emails or phone calls or texts from people that are looking for support with situations like this, I guess we do have conversations of like, well, what if you don't have a milk supply? Like, what does that look like for you? And what does that mean? And allow them to kind of talk it out, worst case scenario, right? So that we can kind of address that and put that out into the open. And then we can create a plan around it. And just in case that happens, just by doing that, I think allow them that time to process. It is a very hard situation.
Just like a short follow-up question for somebody
Yeah.
that does have PCOS or knows that they have hormonal stuff, would it be a good idea as doulas to suggest they see a lactation consultant before birth as opposed to after, or just prepare them in the ways that we normally do for the either or?
Yeah. So I have a slide on that.
Oh.
So for those people that maybe not know what PCOS is, polycystic ovarian syndrome, this is where really hormone levels are different for those people. It's an endocrine disorder, so it impacts estrogen. It impacts so because it impacts estrogen, it impacts their ability to have monthly cycles, or to maybe impact fertility, a variety of issues, along with also milk, because again, it's an endocrine disorder. And so systems that are used to hearing signals and getting those signals and releasing things are compromised. And so with that, then if I know that somebody has PCOS and I know that, and I see them either prenatally or even postpartum, then we do have conversations about, hey, there's the potential that you can have a low milk supply. I would refer them to a lactation consultant. Unfortunately, like for people like me, I couldn't afford a lactation consultant and I didn't have insurance that would cover that. So then I would also refer them to community support groups that would maybe appropriate. So like La Leche League, if that's appropriate. Again, La Leche League has their issues along with a bunch of other community support groups, but that is one. Breastfeeding USA. We have Breast Friends here in Oakland with Brandy. I was going to say Brandy Gates. I think Brandy Gates is Brandy Burgess. She takes in clients as well in the community. So I would double team that to ensure that this person had adequate support that they could reach, that they could afford, that would be accessible to them. But it doesn't necessarily mean that, right? Like, so, but I would, and I think to be perfectly honest, I would do that anyway for anybody, especially a first time lactating person. I would recommend support because it's a very challenging space to be in, and it's a very steep learning curve. And so any kind of support that you can get, is beneficial. But I would recommend that they see somebody just in case they do need to supplement or they need help processing, like what does that mean? Because remember, what I was just talking with you all about today is not something that we're getting in lactation classes. We're not getting this when we're learning about, our sexual reproductive systems. We're not learning about any of this. Which is the reason why I teach it, because I feel like it's so beneficial to know. And plus I love boobs and babies. They're the dynamic duo, and I want to try to keep them together whenever possible. So yes, again, super sorry. Long story short, I would refer them to either a lactation consultant and lactation within their community. And I would also have that conversation of, let's prepare for the worst, but hope for the best, especially with PCOS, because there's not a whole lot they can do about it, to be perfectly honest. If they have hormonal imbalances, that's a really challenging space to navigate. So yes, and then same with my insufficient glandular tissue community members. Those are the people that may not be able to produce milk due to insufficient glandular tissue, and you would see that in pregnancy. So as doulas, you would see that prenatally, you could just ask if they're experiencing any kind of breast changes in pregnancy, if they're leaking colostrum or anything like that. If they do not have any changes in their breasts, especially if they're not leaking any colostrum toward the end, or when you hand express, you don't see any colostrum in the third trimester, that could be indicative of insufficient glandular tissue. And those people, that would be a really challenging that they would definitely have a low milk supply because they wouldn't be able to produce it. And there's nothing you can do to fix that. Finally, gestational diabetes. Research is beginning to show that those that have gestational diabetes could have a delayed onset of lactogenesis too. But one study actually had suggested that those that are treated with insulin will have that delay, but those that are treating gestational diabetes with, I know this could bring some sorrow and great joy, a healthy diet with fresh fruits and vegetables, that there's very little to no delay in lactogenesis too, and babies won't need to be supplemented because their blood sugars don't tank when they get out.
Hello, hello.
I know. I thought that would bring you joy. More and more research saying the exact same thing Samsara's been saying from the jump, but that's all right. It's fine. It's good. It's fine. Any questions or concerns about those that may have a hard time with lactation? How do we support them in both inpatient or outpatient? What kind of conversations are we having with them, and why they might be having a hard time?
I want to point out to doulas also, we get to educate about the help that acupuncture can give for people who are having hormonal issues and other things. I'm sure that there is some science out there on it, but there's also the things that we know, and things like our central nervous system. Chiropractors got the magic stuff for that, and hormonal issues respond well to acupuncture. So that we have wonderful acupuncturists. You want to get the ones that are understanding about reproductive issues and glandular issues, and have a chat with them and see if that can help as
I also want to point out a population that I did not acknowledge in my slide deck, that I feel warrants a bit more of like a call to action, and those are the population with higher BMIs. That there is a delay in lactogenesis too for that population, but also there is another factor that I haven't seen outside of this population, and that is like almost like a structural issue where there's there's some research coming out, qualitative research sharing about how people with higher BMIs feel very uncomfortable with the position, like positioning baby on the breast. Lots of feelings of that they're going to hurt their baby, that they're too big for their baby, that their breasts are too large or pendulous, that could suffocate baby, that baby can't breathe. Lots of different feelings surrounding the size of their breasts or the size of them while they try to mitigate or work through lactation, especially in that very steep learning curve as we transition from lactogenesis 1 to lactogenesis 2. And we're seeing that population is not lactating as long as they would like to want to lactate, or not reaching their lactating goals. But then they're also they're not getting the support that they need inpatient or when they go home, and in terms of how they can find the right position, how they can be empowered with their own lactation journey, and how they can find that their body is the wonderful, safe place that their baby needs to be. I think that's another population I would like to pull out as a call to action for our doulas and how we can support them. I think I just wanted to put that out there as well. Anybody else have any questions or concerns?
I love C.S. Lewis.
Yeah. I'm going to go back for a second. I love how I'm jumping all over my slides today. This is so much fun because you know how like when you develop slides, you know them so well and you have like this speech and I do this when I see that and all this kind of stuff. And you guys have me on my toes today, which I absolutely love. I just briefly want to give a breakdown of galactopoiesis, since that is the most common phase that we know about lactation, which is our supply and demand, right? And there are two factors that control galactopoiesis. The first is feedback inhibitor of lactation, which is fill, or the saying goes, take fill out to fill up, which is a little bit on the ridiculous end of things. But again, I didn't make it up, so I guess I can't talk a lot of shit about it. But really, what the feedback inhibitor of lactation does is that it changes the shape of the prolactin receptor site, meaning that when our cuboidal epithelial cells, those cells that make milk, when they get too full the size of that cell stretches and becomes long, which then changes the shape of the prolactin receptor site, meaning that prolactin can no longer bind to it. It's almost like it changes it from the American plug to a European plug, and you can't put your American plug in it. And because it can't, because prolactin can't bind to it, therefore it doesn't get stimulation to make milk, therefore it stops making milk. And then once that milk is drained, that cuboidal epithelial cell goes back to its normal cube shape, and then the prolactin receptor site goes back to its normal shape, and then prolactin can bind to it and therefore stimulate milk. So that's kind of how like that process goes. And I have a picture because I'm a visual learner. So here's our alveoli. Inside our cuboidal epithelial cells, there's a stretched out cuboidal epithelial cell, a stretched out prolactin receptor site, and then prolactin being unable to bind to it to stimulate milk supply. Just so that, again, we can acknowledge how important language is. I think it's very important to say that, you know, our bodies, when we talk about full or emptying your breast, that we don't want to say that our breasts or chest are empty. So I kind of use it. I love this little, I think it's called a GIF. I don't know. I'm too old for this shit. Anyway, this little small little movie thing that I like to use this analogy for supply in terms of reminding myself of how important language is. And it's like this. So you have a cup, right? Like, let's say you have this cup here that's on the screen, and you have a faucet, or you're pouring a drink into it, whatever, but I like a faucet. You have a faucet and you're pouring water, right? The cup begins to fill up with water. And now you have your straw, you put it in the cup and you start drinking the water while the faucet's still going. While you're drinking the water, the faucet's still going, the level of water will kind of regulate itself based off how much you're drinking and how fast the water is flowing, right? So let's say you take your straw out. The water is going to fill all the way up to the top of the cup, but it's not going to overflow the cup. Water isn't going to overflow out of the cup, right? As it reaches the brim of the cup, much like this glass, the faucet will slowly stop pouring water. The rate of the water will decrease, or almost stop as the cup reaches the very tip brim, right? And then let's say you put your straw back in and you start drinking, then the level of the water will go down. And as the level goes down, the faucet will go up, or the rate of the water will increase. And let's say like it's a really hot day and you're hella thirsty, right? And you're drinking a lot, and the level of the water will go down even more. The faucet will increase its rate of water going in to accommodate the level of water, but it will never be empty, and you will never stop making milk. And I think that's a really important note to take in when we're talking about supply and demand, that the more you empty your breast, it would be the more that you decrease the milk inside your breast, the more milk you make, but you're never fully empty. Because for people like me, when you say, well, you have to empty your breast, then what am I going to do with an empty breast? Like, what if baby comes to me an hour later and I have an empty breast? Like, what do I do? Do I supplement then? I don't want to have an empty breast. And I found that to be really interesting for some of the people that I would support. When they would hear those things, those were the people that would have like formula in their pantry or in their fridge, just in case. Well, just in case, what if my breasts are empty, but I have the formula just in case? Just having that formula there in that house made them feel better, knowing that they had a way to feed their baby just in case their breasts were empty. And that really had changed the way that I describe supply and demand, and full or empty breasts. Okay. Anybody have any questions or concerns about galactopoiesis or how that works? I think I read somewhere that they say if you ask a question, you have to wait like 30 seconds for people to reply. Because, sometimes they're like, oh, I have a question, but I don't know if I should ask it. But then the silence makes people really, really uncomfortable. And then they feel like they have to ask the question.
Mm-hmm.
But I don't want to make people feel uncomfortable. Okay.
Discomfort is not bad for people, my friend.
No. Well, that's good because most of the time I'm uncomfortable. So then I guess that's a good thing. I'm in good company then, right?
Mm-hmm.
Okay. I don't know what your thoughts are, Samsara. Would you like to do maybe another quick 5 minute or do you want to try to plow through and maybe leave a little early? What are your thoughts?
I'm all about bio breaks. Let's do another 5 minutes.
Okay. Awesome. See you guys in 5.
5 minutes. Alrighty, folks. Let us return.
Right. Let's see. While we were on break, did anything come to anybody's minds about things that they wanted to bring up, or that, oh, I didn't know that, or I wish you would say this a different way, or anything like that? Okay. I was going to go over, I could go over breastfeeding positions, but I'm not sure if, I'm not sure if that's what everybody needs. Do you feel that you need support with breastfeeding positions?
I think you should cover everything because we have
Okay.
different levels of expertise here.
Love it. Perfect. Okay. Let's do breastfeeding positions. So I'm going to go over, I think there's a total of 5 breastfeeding positions in these next slides. Now, I always like to start with this caveat that since the beginning of time, we've been providing human milk to our babies, and we have come up with a plethora of breastfeeding positions to do that. This by no means is an exhaustive list of breastfeeding positions, but it is a few that you can keep in your back pocket should you need to support somebody on their lactation journey and they need some better support with positions. There are a couple big takeaways when it comes to positions. One is you need to be chest to chest, belly to belly. Chest to chest, belly to belly. In this case, this baby is not chest to chest, belly to belly, but this is an exception. In most cases, especially in the very beginning phases, chest to chest, belly to belly, right? And the second thing is that if it isn't broke, don't fix it, which brings me to this picture. This is what's working for this dyad, and that's a beautiful thing. If it's working for them and baby's getting enough and we have adequate milk transfer, then I don't need to do anything about it, right? So chest to chest, belly to belly. And then the third thing is that I want to prioritize the comfort of the lactating person. A lot of the times people who are first starting to provide human milk for their babies will compromise their level of comfort in order to achieve whatever latch or position that somebody's suggesting that they do. And that can be problematic because one, they're going to be in this position for quite some time, hours, right? And if you're constantly uncomfortable in doing this act that you'll be doing several times throughout the day and night, then you're not going to want to do it for a long period of time. And I want you, if that's your goal, I want to support you in you doing this for a long period of time. So I'm going to prioritize that person's level of comfort. What does that mean? It means that they may need some pillows. Like you have people that are nesting pillows, like they like to have pillows all around them and support them and do all the things. They're pillow people. And so I'll have a ton of pillows. I'm not a pillow person. Pillows make me feel anxious. And so I found other ways to find positions that worked out well for me. And so if that person's not a pillow person, then we find positions that work best for them. So those are kind of like the 3 general guidelines surrounding positions. Laid back breastfeeding. This is also known as biological, frontal, prone, or ventral. This is good for people that have an abundant milk supply or what they know as a forceful letdown. So that's, remember when we were talking about milk ejection reflex or letdown, this is where milk is able to move fast out of the breast. And by doing laid back breastfeeding, we are allowing gravity to work for us. Let's see if I can move there we go. So here, if I'm laying back, milk has to move against gravity, which can kind of slow the flow down a little bit. And this may be helpful. Also in this position, babies are able to self-attach. So I don't need to do a lot of interventions or support in this situation. You're going to see videos or pictures of this, like when they do like a breast crawl. Like when babies first come out, they can kind of crawl to the breast and they latch on. That would be in this position. I've also, in these pictures that you're going to see, I try to have multiples in there too, because I'm sure Samsara can attest, having multiples is a totally different game than having a singleton, and getting babies on and getting them to stay and getting person comfortable and doing all the things is its own set of challenges. So having pictures with multiples so that when you are supporting that, that dyad, where I guess you're not a dyad anymore if you have multiples, supporting that group, then you can know what positions to use and how that will be helpful. Anybody have any questions about laid back, biological, frontal, prone, or ventral breastfeeding position? Clutch or football hold. This is kind of like how it sounds. Like I said, I tried to have a bunch of different pictures to show you what this would look like. This would be great for people that have had a cesarean birth. That isn't necessarily the case. Some people that have cesarean births don't like this position because, again, diversity is the spice of life and everybody is different. But if with the clutch or football hold, we're not having baby go over the abdomen, or there's no touching the abdomen at all, it's over here to the side is where football is, here or here. And so with that, then we kind of keep that abdomen area clear, which happens to work out for some people that have had a cesarean birth. This can also be really great for our large pendulous breasts. It allows a lot more opportunity to have power over the situation, and so that you can see. This gives you a lot better vision of the baby's mouth and your nipple. For people that have large or beautiful pendulous breasts, you can also, sorry, I was just looking for my, you can also take a, like a baby blanket, or, a hand towel, or a small towel, roll it up like a Tootsie Roll, like a log, and then fold it in half. And then you place it under the breast, under the large portion of the breast. I don't have large breasts, sorry. And it can allow the breast to rest on this towel, almost like a shelf. So then when you get baby attached, the majority of the breast doesn't move. That towel trick is very helpful for anybody that has larger pendulous breasts. This bottom picture here, this pillow is called a boppy, BOPPY, or breast friends. I think it's also what it's called. Are you going to bed? Good night. I love you. I don't think it's called anything else. I'm sorry. Do you remember it being called anything else? I can't think of. Or boppy is what I've.
Major brands. There are other like made up brands names that don't stick in my head like those two.
Yeah. But really what that is, it's a circular pillow. Some of them have like a belt or snap that can attach to your body. Some of them are just like a pillow that you can remove as you see fit without having to attach a strap. And here, as you can see, babies rest on this, and this allows for you to be able to just worry about attachment and not worry about moving the baby or holding the baby or holding your breast. This picture here on the right, I brought this up a little while ago. This is an SNS, also known as a supplementary nursing system. And how this works is milk, any kind of form of milk, artificial human milk like formula or donor breast milk or expressed milk, is put in this bottle. And a tube, a little tiny tube, is attached to it, and then runs flush with the nipple. So it gets taped onto the breast so that when baby starts to latch, it provides nipple stimulation, it provides milk removal from the breast, but also milk will also come out of that tube so that baby's supplemented with extra milk flow. This is great for people that have low milk supply, people that are wanting to induce lactation or cannot provide human milk, but want to have that experience of closeness with breast or chest feeding. Any questions or concerns about clutch or football hold? All right, cradle hold. This is the most common breastfeeding position. Like when you think of breastfeeding or chest feeding, you think of this position. But unfortunately, it is probably one of the most difficult, along with side laying, probably the most difficult position to achieve. And it's really difficult just in terms of power. Who has the power in this situation? If you're trying to get baby to latch on where the baby's head is in the crook of your arm, so you don't really have a whole lot of control here, and I can't really move baby around other than what this arm can do. And then it's also hard to like hold your breast at the same time and get baby latched on. Just a lot of different intricate pieces that make it really challenging, especially in the newborn phase. But over time, it will take practice. And as baby becomes more efficient at removing milk and latching on themselves, then this becomes a pretty easy position to get to. But I mentioned this because for those people that have had a baby before, so if this is like a multip or a person that's had more than one baby or have had experiences with lactation, this is their go-to in the newborn phase or postpartum. Within the first, I guess 1 to 5 days. And it's challenging for them because they're doing this cradle position that they've been doing with their older infant. And now they try to get baby to latch on, and it's a little bit more challenging. So I see a lot more shallow latches with our G2P, 2s and 3s and 4s. When they try to first latch baby on in this cradle position. So I try to mitigate this with the cross cradle hold. And that's kind of exactly how it sounds, where baby starts off, you start off in the cradle position, but I just have them do a quick switch. Actually, you know what? Hold on just 1 second. Hold on. Sorry about that. So this is Grover. Grover is my support person. He was at a Pride pinning celebration, so he still has his Pride thing and my nurse pinning, which I'll take off. So Grover here is a perfect example because he's quite wobbly and he has a lot of arms, and I lost his eyeball. So he's kind of winking at you, giving you a high five. So here we are with cradle, right? And hopefully you can see here. As you can see, it's a bit challenging to get my breast in and to get baby in, but to move to cross cradle, I can start in this position. I'm just going to do a switch of the hands. So if I want to nurse on my right breast or chest, I'm going to take my left hand and I'm going to put it here and support Grover's neck. I usually do it right here at the base of his neck and in between his shoulder blades. That way he can move his head back and forth, but he's still supported by my hands. So I have my right breast and my left hand. This is why they call it cross cradle, because it's my left hand and my right breast, or opposite if I was on my right breast and left hand. So here I'm supporting Grover. And then also, as you can see, I can take my right hand with my right breast and I can hold it here to facilitate a latch. I can either do like a C or a U. But since Grover's nose is going to be here, I'm going to put my thumb wherever Grover's nose is so that I can create a sandwich so more breast tissue can get in there. And we'll talk about that in a minute. And here I can facilitate this latch. And once I feel more comfortable and I feel baby's got a good latch, I can wrap it back around. And here I am back in cradle. So one more time, cross cradle, right breast, left hand. I'm going to facilitate my latch. Oh, I feel much better. This is such a good position. That's a great latch. I'm feeling much better. Now, again, he's chest to chest, belly to belly. I actually have him hugging the breast so his hands have something to do because babies like to knead like cats. And then I can put my hand back around and there I have cradle. So going from cross to cradle. Any questions or concerns about cradle or cross cradle or how to facilitate between the two? I have pictures here too. Excellent. Well, since you are all pretty much experts then in positions, I have this picture and I would like to hear your feedback and your thoughts about why this is a good position or not a good position. Or if you saw somebody do something, would you do an intervention or would you not? Okay, are you ready? All right. Does this look like a good position? If you saw somebody in this position, would you do anything about that?
To me, it depends on if they were latched well. You can't really see their mouth that well. But if anything,
Yeah.
if they weren't latching super well, I'd have them adjust their hand a little bit lower so it wasn't on the back of their head.
Yeah, that's a good one. I like that. So maybe more here in between the shoulder blades. Yep.
It looks like it looks like this parent is like leaning forward. That's the sense that looks pretty uncomfortable, like considering how often
right?
Right? Yeah.
I agree. This person's really leaning forward. That doesn't look like it could be sustainable. So if I did see that, you're right. I would probably be like, oh, let's see, is there a different way that we can make you more comfortable? And I would also, again, just like how Julia had mentioned, move the hand back so that baby can pull his head back as they see fit. And their neck is still supported when you put your hands here at in between the shoulder blades. Yeah. Anything else? Anybody else feel like they can see or would give recommendations to this parent if they saw them? These are all right answers. There's no wrong answer. I mean, everything else kind of checks the box, right? I can't ask them if they're comfortable, but we are chest to chest, belly to belly, and we are hugging the breast, which is also a good thing. So yeah, I think you all nailed it. Move the hand, move into a more comfortable position, and let's see how that works. Excellent. We have side laying position. Again, I tried to get as many different pictures as I could and with many different scenarios. This is a really great position, helps people get some rest to be able to lay down. This is great if you have like a second or third or fourth degree lac or profound swelling, labial swelling. This is an absolutely amazing position, or any kind of back trauma. I see a lot of that too postpartum, where people had a lot of back labor. And then as we start to move into postpartum and provide human milk, right? And we have oxytocin flooding that system, hitting that uterus to contract, that it presents itself in back pain, similar to back labor. So side laying position can kind of help with stretching and moving your back muscles, providing a little bit of more support and relaxation in that department. Ergonomics is really clutch here with side laying. So that's the biggest stressor that I want to emphasize, right? Notice how each one of these people had different arm positions. I threw my shoulder out of whack in side laying position with my first. I had to go see a chiropractor. It was a mess. So practicing safe, good ergonomics, making sure you don't throw a shoulder out of whack is clutch in this position. Again, always want to do the caveat, if we're going to do resting or sleeping or co-sleeping, we need to absolutely practice safety. And that's totally different lecture in and of itself. So I'm not really going to go much more into safe co-sleeping practices, but that would be something that you definitely need to emphasize if people want to practice this position. I have a little bit more of a breakdown of what that looks like. Again, latch, and we'll go over what latch is in just a little bit, but we want to make sure we have a clear pathway. I like the V. This is a really great breakdown. And then how we're going to apply pillows. Where are pillows going to be? In between the thighs or in between the knees, behind the back. We want to obviously have a clear space because we're going to practice co-sleeping, safe co-sleeping. But yeah, that's much side laying. Does anybody have any questions or concerns about side laying position? I see something in the chat. Right? Oh, it sucked when I threw my shoulder out. And when you got it cracked back, oh, it's just really crazy. I hated it. I regretted it. I still did side laying, but I made sure I was way more proactive about making sure my shoulder wasn't out of whack. Any more questions or concerns about side laying or any other position? I'm pretty much done with positions at this point.
I don't have a question or concern. I guess it's a comment because now the medical people are doing such a good job of scaring people to death and like, don't sleep with the baby and don't have the baby in bed with you. And I'm just like, can somebody give these folks the memo around safe sleeping, and can we give them the memo around how people have slept with their kids since, the beginning of time, a mammal's this behavior, because it's a really and docs are not generally not taught about lactation at all, so folks could just stay in their lane on that. I mean, I'd be happy about that.
Right? It is a very touchy subject, honestly. And every time I bring up side laying, there's a lot of challenges around it. What I do appreciate is that at least the lactation consultants that I work with and inpatient at the institutions I've been at do teach side laying and incorporate it, when they're in the hospital. So I see people doing side laying when I'm coming in, and I feel like, oh man, that's great. At least they have that skill set. At least they have that ability to provide or to do that position. But you're absolutely right. Wasn't it? I want to say at least like 3 years ago or something, the American Academy of Pediatrics said that they recommend against co-sleeping. And I thought that was really interesting that they did that. Because the World Health Organization does not. The World Health Organization does not recommend against co-sleeping.
Well, I think somebody wrote a nice big check to make that go down, but
good point.
I'm not surprised that such non-helpful things come out of
right.
American Pediatric Association says sugar has no effect on children.
Oh, nice. Nice.
I'm not impressed by all the letters. Common sense. I mean, there are things that make co-sleeping not very safe, and we definitely should teach and talk about those things. But for the most part, that's the best. I had a client who was very stressed out. Her milk supply was going down, and she wasn't figuring out why. And she and I were chatting, and I said, are you sleeping with your baby? Is the baby with you, close to you? And they're like, no, the baby's in a bassinet, like more than an arm away from the. And I was like, try this for me. We'll, give it a try. Have move the baby closer to you. Move the baby close enough so you can smell it. You can smell the top of your baby's head, which is like the sweetest smell ever in life. And she tried that, and actually she just put the baby in the crook of her arm, as so many nursing parents have done since forever. And she sniffed her baby's head all night, and she woke up leaking milk, like leaking.
Yeah.
In her bedclothes. And she called me crying with happiness. And I was like, I'm happy for you, boo. You guys are still the same person,
Yeah.
You need to, baby needs to smell you and vice versa. Smelling your baby helps your body do a lot of the going back to homeostasis after you've given birth. So you guys need and enjoy that, because they get to a point where they don't want to talk to you and mommy.
Right? Yeah.
Now when you get to snuggle them close and sniff their head, enjoy it. So yeah, so that was just my problems are created when we don't look at the biological imperative of what we're doing and what we're doing for our kids.
Yeah.
And then there's the piece about, yes, there's a biological imperative, but we don't live in the villages anymore. How can we create the villages that we are designed to live in? A baby is not a two-person job or a one-person job. Each human kid is about 50 people.
Yeah.
So how do we mitigate that?
Yeah, all excellent points. Absolutely. Anybody else have anything to say about side laying or head sniffing? It's a beautiful thing.
Beautiful thing.
It's a beautiful thing. I still do it. I know my kids ask, Mama, what do you want for your birthday? I said, I just want to lay in bed and cuddle and kiss all day. Let's just lay in bed, cuddle and kiss all day. Because I just love, even though they wash their hair, still my babies. Okay, just in terms of going back to language, right? When someone says tandem nursing, I'm tandem nursing. What does that mean? It just means that more than one child is benefiting from their human milk. It could be their babies. It could be their baby and another baby. It doesn't matter. If somebody says I'm tandem nursing, more than one person is getting their milk in some fashion. I don't really speak a lot to nipples, but I do want to kind of go back earlier in our conversation this evening. We spoke about fluid intake or edema and how that can impact milk travel, like through the ductal system, along with compression of the breast, but this can also work for nipples. So as the breast becomes edematous, then so does the nipple, which makes it puffy or challenging to latch onto. And that can impact milk supply, right? Because if the nipple is a challenge to latch or we have problem latching, we can really damage that nipple as well as impact milk transfer, meaning milk leaving the breast and going into the infant. And the rest of these are, I'm sorry, I crossed this out. This said it was normal. My nipples are normal. Your nipples are normal. Everybody's nipples are normal. This is an everted nipple. There's variations of inverted nipples. Most nipples are can breastfeed. Inverted just means that when there's no suction, it inverts in itself, but when there's suction or stimulation, they become everted. I call them kind of like the jack in the box of nipples. They're here, but with pumping or stimulation or sucking, then they become inverted or everted. Staying on the topic of nipples, the bumps that we see around the areola, those are known as Montgomery glands, and Montgomery glands really do two functions. One is they secrete a fluid that will provide lubrication, just to protect the areola and the nipple. The second is that lubrication is said to have a very specific odor that's similar to amniotic fluid. So this is why they recommend don't wash your nipples, because it will mask this smell that attracts babies. There's a study that's linked on this slide that exposes a 24-hour-old infant to various Montgomery gland secretions. One is its mother's Montgomery glands or its birthing parents' Montgomery gland secretions, another human's Montgomery gland secretions, and then a variety of different mammals' Montgomery gland secretions. Like I think it had like a gorilla and a dog, and I can't remember what else, but the baby only showed hunger cues to its own mother's Montgomery gland secretion. So it's a very, very specific smell, and hope to attract a baby to the nipple. Okay, Any questions or concerns about nipples, edematous or Montgomery glands or anything else of the sort? All right. I'm going to do latch. I'm going to try to get latch done in 15 minutes. We'll see. And then we can watch the videos associated with latch when we return with each other next week so that it can be like a refresher. That's my goal. Anybody have any questions or concerns about plowing through latch? Everybody feel ready to get your latch on? Okay. I didn't hear any objections, so I'm going to move forward. So the saying with latch is nose to chin, then roll it in. Again, it makes absolutely no sense, but I didn't make it up. So again, I can't really talk smack to it. But this is why they say nose to chin, roll it in. So we want to achieve what's called an asymmetrical latch, and I'll go more about this in a minute. But in order to achieve this asymmetrical latch, our starting point needs to be with the baby's chin touching the breast. And as a result, the nipple will point at the nose. Hopefully you can see that. Grover's got an amazing nose, which is really helpful with lactation. So his chin is touching. As a result, the nipple is touching there or aimed at the nose. Because baby, I'm holding his shoulder blades, he's going to bring his head back. And as he brings his head back, he's going to open his mouth nice and wide. And then I'm going to roll him onto the breast. Okay. That's why they call it nose to chin, roll it in. But the saying is to prompt you to have baby's chin touching first. And then as a result, the nipple touches the nose. And I'm a picture person, so there's going to be tons of pictures here. So again, we should have be chest to chest, belly to belly, and baby needs to hug the breast. Baby needs to have their arms around the breast. Then chin will touch the breast, and as a result, the nipple will touch or aim towards the nose. The baby will bring their head back, just kind of like how everybody, if you notice, next time you take a bite of a sandwich, you bring the sandwich to your face. And as you're going to take a bite of the sandwich, you swing your head back to open your mouth. It's an ode to our previous breastfeeding selves that we hold this sandwich. I'm going to take a bite of the sandwich and I'm going to swing my head back, and then I'm going to bite the sandwich. That's the same situation here. Okay. Now, you may have heard people say, I'm going to sandwich the breast. I actually referenced it when we were doing positions where I'm going to sandwich the breast. And I sandwich the breast in like a C or a U, but I use the baby's nose as a guide. So what does that mean? So here's my breast, right? And I want to do cross cradle, right? So if I'm going to do cross cradle, Grover's nose is going to be on this side of my breast. Hopefully you can see my finger. So here, I'm going to put my thumb where Grover's nose is, and then I'm going to compress the breast. As I do that, I have a U shape with my hand, right? And Grover's mouth is going to go here, and it's going to latch on like this. So then I get more breast tissue in baby's mouth instead of on the nipple. And that's how we can sandwich the breast. Now, do people need to sandwich the breast? Not all the time. It doesn't have to happen, but it's a good thing to use in order to ensure that those latches have enough breast tissue. Because again, milk does not come from the nipple. That's not where milk is made. Milk is made here and it's delivered, pushed out through the nipple. The nipple is just like a catalyst. It's not going to be helpful. I need to get all of the breast tissue in the baby's mouth. Okay, I have more pictures. So once again, I want to achieve that asymmetrical latch. What does that mean? It means I'm going to have more areola on top, less on the bottom. I need that asymmetrical latch because that's how I'm going to get more breast tissue into the baby's mouth. I do that with the chin touching, and as a result, the nipple is pointed towards the nose. Baby's going to swing their head back and take big, huge mouthful. And as a result, I will have more areola on top, less on the bottom. Okay. Another thing I'm looking for with a good latch, besides having chin touching and more areola on top, less on the bottom, is fish lips. Fish lips are what create an airtight seal around the breast. Now, remember, like I said, babies remove milk via compression. They don't remove milk via suction, but they do stay on via suction or through this airtight seal that's created with their lips. Another thing I want to point out that you may not see in the newborn, but you'll see later on, is that tongue coming up and over the gum line. Hopefully you can see it right here. That tongue needs to come up and over the gum line because, like I've said, babies remove milk via compression. So the tongue comes up and over the gum line, has the nipple. If this is my tongue here, this is my tongue. The nipple is going to rest here as I open my mouth. And when this is the top of my mouth, the roof of my mouth, when baby nurses, it presses the breast against the hard palate of the mouth and then release it. It almost does like the worm. Did anybody know the worm? Am I dating myself? You know, the dance worm, the dance move the worm. You know that, right? Sorry, you know the worm, right? Where they lay on the floor and they do the worm. Maybe I'm dating myself, but
no,
yeah.
I
So
know the worm.
right. There we go. The worm. Okay. So the tongue is basically doing the worm, right? So it needs to come up and over that gum line. And as the breast goes all the way in the back of the mouth, the nipple rests in the hard or the soft palate of the roof of the mouth. So then when the tongue compresses the breast against the hard palate, the nipple is free inside the mouth or against the soft palate. Now, with clean hands, if you feel the roof of your mouth and go a little bit further, you'll feel it be hard, and then it'll be soft. That's where the nipple needs to be. And when the tongue presses against the breast, then the nipple is free and clear of being compressed against the roof of the mouth. If it's not, if the nipple is shallow, then what's happening, the tongue will press the nipple against the roof of the mouth, causing it to crack, causing damage, blistering, and then eventually bleeding. And a way to know that you have the nipple all the way back towards the soft palate of the mouth is when the nipple comes out, the nipple isn't elongate. It's not pinched like the tip of my finger. The nipple should not look like the tip of my finger. It should look like how it came in, right? If when she pulls it out and it's still pinched or red, that was a shallow latch. And you're like, Laura, this makes no sense. I need more pictures and videos. And you got it. I'm going to show you pictures and videos. Okay, this is a 24-hour-old. This is kind of going to like take in everything I've said and apply it all at once. Okay, so bear with me.
Just nice and snug here. Okay, so if you'd like to do cross cradle, you get your hand supporting your breast. The big sister's gonna
You are. We're good.
Okay, let's see. So sorry about that, y'all. Let's see if I can get you can just finish off with this one super here. Okay. See if I can make this work. Okay.
Just nice and snug here. Okay, so if you'd like to do cross cradle, you get your hand supporting your breast. The big sister's going to help us. And then you're going to just gently run the nipple on the upper lip and wait for him to open wide. Wait for him to open nice and wide. And then bring him in from his back.
Sorry.
Okay, now it could be, let's let him come off because that wasn't as good as it could have been, and he says also. So run the nipple slowly. And deeper from the back, and squeeze the breast. Squeeze, squeeze, squeeze as he comes on. So it's not my hands in there, but your hands.
There.
Nice drinking already. There. There. You see how the chin drops down and pauses? There.
Try the compression now. Get a good handful of breast and get the milk flowing.
There's a mouthful. There. See how the chin drops down? Yeah, there. And this baby's only a day old.
Okay, so I'm sorry that the video cut out. Hopefully this makes a little bit more sense. I think that some of the big takeaways from that video, right, when again we're doing cross cradle, that baby starts with the chin touching the breast, and as a result, the nipples at the nose. Now that baby was upsetty spaghetti. It's very challenging to get upsetty spaghetti babies onto the breast. If that baby remained to be that upset, then we would need to try to calm that baby down before we try like reorient that baby and then try to get baby on breast at that point. But we were lucky to kind of catch it right at that moment where he was able to tolerate us doing what we were, them doing what they were doing. This is a oh, so I'm sorry, the name of the guy is out of my brain. It's not Dr. Kale, it's
Dr. Jack Newman.
Dr. Newman. And he has all these amazing videos on latch and position. And this is one of my most favorite because I feel like it kind of just accompanies all of the pieces, right? The pillows, the setup, the breast compression, because remember, moving milk down that ductal system so that baby gets that immediate reward. And then you see him as he hugs his boob at the very end. Every time I see it, I get teary-eyed. It's such a great video. Okay, again, I'm so sorry for the technical difficulties, y'all. I will be sure to be more proactive about making sure my computer stays engaged. Does anybody have any question, concerns about, and we'll go more over latch when we meet again. I know this is kind of a brief overview and we'll go more into depth because I feel like latch is a hot topic. But
there's one thing that I would say is that I was feeling a little uncomfortable when the baby appeared to be upset.
Yeah.
So I know that little ones, they scuffle and they get all upset and the boob's right there and they're still acting crazy, and we all know that.
Yeah.
We do want to let clients know that, like, if baby is upset, maybe we kind of stop, take a break, come down, start it over again. Babies like breast milk. But they just get overwhelmed, and then there's a voice in the background talking to stuff. I mean, I love Dr. Jack, but he still does those things sometimes that white guys do. So I just want to have we want the nursing parent to be empowered as well as the baby.
Absolutely. Yeah, I agree. It is one of the least favorite parts of this video. Boobs don't really like being yelled at. And that's, but it is part of this. And I feel like I like to kind of introduce this video very early on, because sometimes when you're supporting lactating people or that dyad, this is kind of what you walk into, an upsetty spaghetti baby. And that person's very stressed out because the baby's upset. And we now have to try to keep calm and we got to keep calm and latch on, right? Like that's the goal. And so, but I agree. I should preface this video before showing that the baby is upset, because it could put people in some dark places. Yeah.
Not to mention little babies.
Of course, yeah. I mean, he was upsetty spaghetti. He was until but he got it. He figured it out. He's crushing it.
It's just a matter of waiting 5 minutes.
Yeah, I agree.
Snuggles and hugs, and let's try again.
Little skin to skin to reorient. Absolutely. Yeah. Anybody have any questions or concerns for me? It has been a pleasure to be with you all this evening, even though we were coming from all kinds of different places.
Do we still have a part 2 with you next week, right?
Yeah, next week.
Ooh. Was someone going to say something? I thought I heard a voice.
Yeah, I have a quick question. So with touching the nipple to the nose, like the chin and the nose, to get baby to open wider, well, there are, some babies who had a hard birth and maybe for whatever reason, they are not able to open wider or something hurts. Like, I understand that, we can't force them to open wider, obviously. But is there like any techniques to support in the moment so that mom is not over flustered because the baby's not wanting to open up to take the
Yeah, no, that's a really great question. And that's something I see a lot in the hospital. There's been moments where I wondered if baby needed to have some kind of, maybe craniosacral manipulation, or there needs to be some kind of jaw release. That's definitely something I've seen. And that's really within the scope of the lactation consultants to assess whether it needs to like some kind of oral structure there, or the pediatric team to be able to assess if there was an oral structure there. Things that I would do to facilitate that is I feel like, again, going back to where parents are more than happy to compromise their comfort or their pain in order to get some kind of latch. And I feel like we need to be very diligent about establishing that latch very early on with that big open mouth, and not to do it otherwise. So if we can't get that open mouth, then assessing a suck, and then possibly doing some hand expression on a fingertip or on a nipple tip to rub against the nose or the lips to really facilitate, like, oh, I'm getting food and calories, and to really draw in that instinct to open their mouth. Because if they can yawn and they can cry and they can yell, then they can open their mouth. If they cannot yawn or cry, then that may be a reason, then that's a whole different story. So eliciting with milk removal on the nose or all over the lips, and being patient, even when baby is upset and crying. If we need to console and then try again, then that's what we need to do. But really being patient and waiting for that open mouth, which is very frustrating and super easier said than done. Really easy for me to say that here. Very challenging in this space.
And an infant's cry is really designed to strike a chord in its parent that is painful as hell.
Yeah.
So it is really hard for a mom or a parent to hear that and see their baby going through that, even if it turns out well in the end.
Yeah. And I acknowledge that. I say, baby's going to cry and it's going to make you feel some sort of way. And I just want to remind you, at this very moment, you are safe. Baby is safe. We're going to try to do this, and we're going to give it a minute and give it a good go. And then we'll come back and we'll calm, and then we'll try it again. If at any time you need to be all done, you just tell me you're all done. Right? We put the power there, but we also acknowledge the fact that it is just, it is gut wrenching to hear it. Even now, my kids are 12 and 11, and I just can't. It's a lot.
People were in their 40s. I want them smiling all the time. Happy people. Happy.
All the time. Happy.
Well, we are at 9:04. So if there's no more comments or questions, I would love to say good night to you, dear friend, and look forward to seeing you again next week.
Absolutely. It has been a pleasure and an honor to be with you all this evening. Thank you so much for your time and your questions and your engagement. And it's so nice to see your beautiful faces. And I hope I get to see you next week. Thank you so much for your patience and understanding in my technical difficulties.
Thank you.
Thank you. See you guys next week.